So, Dr. Murthy, thank you so much for joining us today. We're very excited to have you to talk about the new FDA approval of Tucatinib. So, in light of that, the FDA has approved the use of Tucatinib in combination with trastuzumab and capecitabine for the treatment of patients with unresectable, locally advanced, or metastatic HER2-positive breast cancer, including patients with brain metastases following at least one prior therapy. So do you think you could start off by discussing the rationale of the triplet therapy, as well as what previous findings did we have on the use of Tucatinib in this space?
Sure, thanks for having me. So tucatinib is a HER2-specific tyrosine kinase inhibitor. It's an oral drug, and it has really two very important features that I'd like to highlight. So the first is its HER2 selectivity, and then the second is its ability to cross the blood-brain barrier. And these two features really make it a great addition to trastuzumab and capecitabine. So what we know from in vitro assays is that tucatinib is highly selective for HER2. In fact, it has a greater than 1,000-fold selectivity for HER2 over EGFR, which really translates to a more favorable toxicity profile. We know that blocking EGFR often causes additional toxicity such as rash and diarrhea, but yet it doesn't seem to improve upon the efficacy of HER2 blockade, as we've seen in prior studies in the field. And so this feature of tucatinib is really important and differentiates it from the other small molecule inhibitors and translates into significant clinical impact from the perspective of tolerability and quality of life for our patients. So the second feature is its ability to cross the blood-brain barrier. And we know that the active metabolite of tucatinib does in fact do this. And this is supported by preclinical work that has shown that tucatinib treatment significantly enhanced survival in HER2-driven intracranial tumor xenograft models in mice. And this key potential for tucatinib has really been critical in our minds since the early development of the drug, as brain metastases represents a really significant problem for patients with HER2-positive breast cancer. And we've had an urgent need to develop systemic therapies that target the disease when it does spread to the brain. Finally, results from the phase 1b dose escalation study really set the foundation for the HER2CLIMB randomized trial. And the results from the dose escalation study showed that the combination of tucatinib at the phase 2 dose of 300 milligrams twice a day, combined with capecitabine and trastuzumab, was really had a really easily managed toxicities, in addition to very encouraging anti-tumor activity in both patients with and without brain metastases. So this really, this clinical data from the early trials really set the foundation for the HER2CLIMB study.
Perfect. And speaking a little bit more about the HER2CLIMB study, do you think you could just expand a little bit more about the key findings from that, as well as how this study has paved the way for the FDA approval of Tucatinib?
Sure. So HER2CLIMB was a relatively large trial of over 600 patients. And on the study, all patients were treated with trastuzumab and capecitabine as their backbone therapy, and then randomized to either the addition of tucatinib or placebo. All patients enrolled had prior exposure to trastuzumab, pertuzumab, and TDM1. There's one key eligibility criteria that I'd like to highlight that really sets this trial apart, which is that patients were allowed to enroll if they had brain metastases. And this was not limited to patients who had stable and treated brain mets, but also patients who had new disease or previously treated progressing disease in the brain who did not require urgent local therapy were also allowed to enroll. So it's really important to highlight here that the trial allowed for a very high-risk patient population to enroll, those who were heavily pretreated and those who potentially had active brain metastases. The results of the trial showed that the trial met all four of its endpoints, so progression-free survival, overall survival, progression-free survival in the brain mets population, as well as objective response rate. And we saw that when tucatinib was added to trastuzumab and capecitabine, this resulted in a 2-month improvement in progression-free survival, both in the patient population with and without brain metastases. Further, there was an unprecedented 4.5-month improvement in overall survival in, as I mentioned before, a very high-risk patient population. The benefits from Tucatinib were noted across all the clinically relevant subgroups. And finally, there was a near doubling in the confirmed objective response rate with the addition of Tucatinib. Focusing a little bit on the patient population with brain metastases. So from the trial, approximately 50% of the trial population had brain metastases. And so this is very reflective of what we see in the clinic as well. And of the patients with brain metastases, approximately 40% had either new or progressing disease in the brain. And one of the most striking results in my mind from the HER2 CLIMB study was that among patients with brain metastases who received Tucatinib, a quarter of them remained on trial at the 1-year time point, whereas among those with brain metastases who did not receive Tucatinib or who received placebo, none of those patients remained on trial at 1 year. So we certainly do need to do better than 25%, but this is a really huge step forward for our patients, and all of these trial results in sum really paved the way for the FDA approval that we've recently heard about.
Wonderful. And I know you did kind of answer this a little bit, but maybe you could elaborate upon it a bit more. So this was the first investigational therapy in a pivotal trial to include patients with HER2-positive metastatic breast cancer who had active brain metastases. So do you think you could speak just a little bit more about the significance of that?
Sure. So that's correct. So HER2 CLIMB is the first randomized trial that I'm aware of that's included this very high-risk patient population. So where most trials allow patients to enroll if they have a history of brain metastases, most of them require these brain metastases to be stable and treated. And HER2 CLIMB had a very unique eligibility criteria in that it allowed patients with new disease or progressing disease. And this decision to allow this high-risk patient population, I must note, was very well supported by robust preclinical as well as the early clinical data showing that there was significant potential for Tucatinib to cross the blood-brain barrier and positively impact patients with this significant problem. I think this is really important because brain metastases are very frequent with HER2-positive breast cancer and represent a very significant problem. Up to half of patients may develop disease in the brain, and there is, we know, continuous risk for this over time in patients with metastatic HER2-positive breast cancer, meaning that as patients live longer with advances in targeted therapies that may control their systemic disease, they still remain at risk for spread of the disease to the brain. Also, we have not really seen that advances in neoadjuvant or adjuvant targeted therapy have really been able to address this problem. And so there really remains a very great medical need to develop such therapies that can cross the blood-brain barrier. And hopefully we will have many more such trials and hopefully more drugs that will follow this example.
Well said. So do you know of any other trials that are now including this population in their analyses in light of this work? And if you don't, do you think you could explain a bit on why they should be incorporated?
Sure. So the HER2 CLIMB 02 study is currently ongoing, and this study is evaluating the addition of Tucatinib or placebo to TDM1 in patients with advanced HER2-positive breast cancer who previously progressed on trastuzumab and a taxane. And this trial has a very similar eligibility with regards to the patients with brain metastases as the first HER2 CLIMB study that we've just discussed. There's much need for, further development beyond Tucatinib, of course, and hopefully we will see more drugs in the coming years that may help this population of patients. I think that what we have realized is that, as a community, one of the keys to developing trials or developing drugs for a high-risk population such as this is really to start with preclinical efforts to identify drugs that have the scope to cross the blood-brain barrier, and then move these compounds into early phase trials that can really set the foundation and give us the confidence to then enroll patients into randomized trials. I think the development of Tucatinib over the years has been a great example of starting from preclinical, moving into early clinical, and then really has set the foundation for the impressive results that we've now seen in HER2 CLIMB, the randomized study.
So you did speak to this a little bit, I believe, in the first and second question that we were talking about. But from the HER2 CLIMB study, do you think you could talk about the safety profile, what that looks like in this combination?
Sure. So what we saw is that tucatinib did not really add much more in terms of toxicity, and the combination is a very attractive treatment option for patients with metastatic disease because of potentially not affecting their quality of life in a negative way. The randomized study was really able to confirm the safety of tucatinib when added to trastuzumab and capecitabine. And the most common side effects that we saw were diarrhea, hand-foot syndrome, nausea, fatigue, and vomiting. And these are all mostly low grade. They're all manageable with supportive therapy. And often we see many of these side effects even in patients who are on capecitabine plus trastuzumab alone. Potentially some of this is also related to capecitabine. There were not really any significant EGFR-related toxicities that we couldn't manage. And this is something that we had expected given the drug's unique property of being HER2 selective. So in summary, the regimen was confirmed to be very safe and tolerable for patients.
Perfect. So as you mentioned, you did talk about diarrhea and hand-foot syndrome. So while reading about this trial, the risk of diarrhea and elevated aminotransferase levels were found to be higher with tucatinib. So do you have any advice for managing these events in practice?
Yeah, so diarrhea was the most common adverse event, but this was the case in both the tucatinib group as well as the placebo group. And most of these events were really low grade. Antidiarrheal prophylaxis was not mandated on this study. However, it was introduced as needed, and the median duration of use was short in both arms, about 3 days per cycle. So certainly the diarrhea that was seen on this study could be well managed. And so I would recommend certainly that patients who develop diarrhea while receiving this treatment do go ahead and get started with antidiarrheal treatment to help manage this. As far as the elevations in liver transaminase levels, these were, again, all mostly low grade. And they were, when they happened, they were transient and they were reversible. I think it's really important to highlight that the most common reason for treatment discontinuation on this study was not adverse events, but actually disease progression. So there were very few patients who had to actually discontinue treatment due to adverse events, approximately 6% in the tucatinib arm and 3% in the placebo arm.
Perfect. So talking about tucatinib in the grand scheme of things, how will the approval of tucatinib change the treatment paradigm of HER2 positive breast cancer, and how will it impact clinical practice?
Sure. The approval of tucatinib provides a key treatment option for patients with HER2 positive metastatic breast cancer now. Its favorable toxicity profile and its activity across the blood-brain barrier really makes it a very attractive option in my mind. The overall survival benefit is really unprecedented in this heavily pretreated patient population. And so its approval allows us to improve outcomes for patients and really expand the treatment options that we have available for patients with and without brain metastases.
Perfect. And are there any unanswered questions with this combination that future research efforts should address?
Yeah, so I think, there's certainly a great number of unanswered questions, and this is a really important data set that we now have. I know many of us are looking forward to see what was the intracranial response rate and duration of response in the patients with the brain metastases at baseline. Also, it'll be really interesting to see the rates of progression in the brain among patients who did not have a history of brain metastases at the start of study entry. Further, patients were allowed to have local therapy if they had isolated disease progression in the brain. So it'll really be interesting to see the outcomes for these patients. Also, I think a key question is, what is the activity of tucatinib after patients have been exposed to other tyrosine kinase inhibitors such as neratinib or lapatinib? And then there are several efforts ongoing to look at whether tucatinib may have a potential role in an earlier line of therapy, like the HER2 CLIMB-02 study I mentioned. And then also to see if tucatinib could be brought in even earlier, like for example, in the adjuvant setting to potentially prevent patients who are at higher risk from developing metastatic disease or even spread to the brain.
Is there any other interesting work being done with tucatinib that you wanted to highlight? And let's see, do you foresee tucatinib being explored in the front line?
Yeah, so I think certainly one very interesting clinical trial that's going on right now is to see if the combination may be helpful for patients with leptomeningeal disease. So in some unfortunate situations, breast cancer can actually spread into the leptomeninges. And when this happens, we know that prognosis is often very poor for these patients and treatment options are quite limited. And so seeing the unprecedented results of the HER2 CLIMB study really makes us hopeful that this might be a great treatment option to also help patients with leptomeningeal disease. And there's currently a ongoing clinical trial that's enrolling at several sites across the country through the Translational Breast Cancer Research Consortium. So certainly would encourage patients or physicians to refer patients that are that may have leptomeningeal disease to that study. And as far as your second question about moving it to the frontline setting, I think certainly with these results, the natural next step would be to see if we can introduce tucatinib even earlier on. And as I mentioned, there is already an ongoing study, and then also efforts in even the curable setting to see if we can actually prevent patients from developing metastatic disease.
That all sounds like very exciting research, so thank you for highlighting that. And then my final question for you, Dr. Murthy, is what is your take-home message to your colleagues?
So I think the key take-home message is that tucatinib, when added to the backbone of trastuzumab and capecitabine, reduced the risk of death by a third in heavily pretreated patients, including those with brain metastases. And it also reduced the risk of progression or death by a half in this heavily pretreated patient population. The strong efficacy data, as well as the tolerability profile, really make it a great treatment option to consider for patients with metastatic HER2-positive breast cancer, both with those who have brain metastases and even those who do not have brain metastases.
Perfect. So, Dr. Murthy, thank you so much for your time today and for talking about this very new, exciting approval with me. And just thank you again.
Thank you so much for having me.
Of course. Have a good one.
Take care.